Hi, my name is Rich Boyajian, and I'm a nurse practitioner that's going to talk to you today about how technology might improve survivorship care. I also wanted to thank Dr. Lenekodoff and the survivorship board members for inviting me to give this talk today. I also wanted to take the time and acknowledge Dr. Jay Burton, whom I consider a kindred spirit. So before we dive into it, I wanted to give you a little bit of my background. So I've always been a tech geek, ever since, again, I'm older, so I remember when email and everything came out, and I've always been playing around with technology since then. And I've been a nurse practitioner in the Dana-Farber Brigham and Women's System, well, now for more than 20 years. I've done many different things, running clinical trials, being part of multiple different disease center teams, and I've also been the assistant director of the Adult Survivorship Program. Right now I'm in the Department of Radiation Oncology, and I've developed a virtual prostate cancer clinic, which we'll talk about more in a minute. But knowing the audience of this talk today, I also wanted to give you additional background of how I got this start in oncology. So it goes back to 1995, actually, when I married my college sweetheart. And less than a year later, I was diagnosed with leukemia. And I can, my wife will tell me how I got last rites in the ER, but thankfully they told me that the one shot I had at survival was an unrelated donor stem cell transplant. And so lo and behold, I'm also a survivor, and that's actually how I got my start in oncology. I was a nurse at the time, but I decided because of the care, amazing care I got, not just because of the physical care, but as most survivors know, the emotional toxicities of diagnosis and treatment are often as difficult, if not more difficult. And I was amazed at the care, not only that they were able to care for me physically, but they were there for me to pick up the pieces emotionally, because this was not an easy time, as all of you know. But so basically, I went back to school, became a nurse practitioner. Before I went back to school, I was a non-compliant patient. This is about a month after my transplant. Didn't ask my doctor, Dr. Joe Anton, for permission. I basically told him later that my niece was being christened and I was her godfather. So I went to the christening, even though I was supposed to be in total isolation. So I'm not the perfect patient either. And then after treatment, really what I think of it as is we're trying to resume our interrupted lives. And thankfully, the bone marrow transplant gave me a second shot at life. And if you see here, this is my college sweetheart. I'm trying to use a pointer here. There we go. And that's my college sweetheart, Pauline, who we've been married now for, we're going on, it's been 27 years, but 26 years ago was when our life changed and I underwent a bone marrow transplant. And as you can see, I have two lovely daughters. We have Crystal and Shayla, or maybe updated here. We have Crystal here and Shayla here, but I owe it all actually to my social worker, Mary Lou Hackett, because Mary Lou was persistent when I was being diagnosed before my treatment and insisted and wore me down, and I finally did donate sperm because at the time I didn't think it was important because I was young, just newly married, and that was the last thing on my mind. But I thank God for Mary Lou every day because she allowed me to have a wonderful family, with Crystal and Shayla, with Crystal graduating from BU and has a social media and journalism degree, and now that the pandemic is finally done, is looking to begin her career. And the youngest daughter, Shayla, finished up dancing in a large show in Vegas and is now going to be on Royal Caribbean. So that's just a dad brag for you guys. But really, it is about resuming your normal life as much as possible. And after my transplant, I had to go in, and I lived about an hour away, but with traffic it was about 2 hours. I lived about 2 hours each way from Dana-Farber, and I had to go in there 3 days a week for probably over a year because of blood counts and needing to be checked and things like that. And that's when I first got the idea of there's got to be a better way for this. I also wanted to say that, like every other survivor, the treatment that cured me, thankfully, unfortunately, did have repercussions where, I developed some heart issues with cardiomyopathy. I had both my hips replaced in my 40s. I had cataract surgery in my 30s. But again, my quality of life, is excellent. I have a great life with my wife. I've been, this is me at the Bruins finals where they lost to the Blues, and this is me with a bad dye job on my beard, but playing hockey just a couple years ago, and just lost in the finals of an over 50 tournament. So I do know that life goes on, but survivors need care, and that's kind of where I've always been. That we need care after treatment, and for me, survivorship care means disease and toxicity monitoring. And although that seems simplistic, by toxicity monitoring, I mean not just the physical complications, but the emotional, psychological, and financial toxicities of treatment as well. And basically, it's screening and monitoring for these issues. It's treating what issues develop, but it's also educating survivors about what their disease follow-up is, what toxicities we're looking out for, and what we would do about them, so that not only we're educating them about what could happen, but we're empowering survivors to be able to do more on their own. And I know that's what Dr. Burton wanted more than anything, was to to improve the quality of life of survivors after treatment. So this is basically, I'm going to show you a journey that we've all gone on, and just to put it in a different perspective, because having worked in oncology a number of years, I realized that there's two sides to each coin. And so Norm just got diagnosed as, we're going to use prostate cancer, high-risk prostate cancer, and he seeks out the best physician in the world, Dr. Tom Brady. Well, Dr. Brady, unfortunately, he can't see Norm for about 2 to 3 weeks. So obviously that causes Norm a lot of anxiety and fears, wondering what's going to happen. That fear of the unknown is one of the worst things for a survivor, and also for his family and loved ones. So he has to wait, and the reason why he has to wait, is Tom Brady, Dr. Tom Brady, there's 3 parts to what he does. And, obviously it's seeing newly diagnosed patients to get them into treatment. Then he has the patients on treatment. But then he has those patients in disease, and toxicity surveillance. And that's where you come in each time. You come in and you get your tests. And so for prostate cancer, you're getting a blood test, and you're filling out a survey about what toxicities you might have. And then, you spend the time and you come in, and you also will go over your, have you relapsed or not, explain kind of where it's at, and talk about any symptoms you might be having of the toxicities. And again, that's probably a 10 to 15 minute talk, and you actually probably spend more time getting there. But he spends a lot of time seeing a lot of the survivors, which is a great thing because we're alive. But again, it also delays care for other people. So I thought there's got to be a better way for that. So Norm finishes, gets his treatment, it's doing very well, and he enters this phase where he's now part of that follow-up group of survivors that we're not worried about the disease at this point. We're worried about monitoring for it to come back, and we're also worried about toxicities that might happen. So the other thing that, as a provider, we don't often think about is, well, Norm has to travel. So, and I know I'm talking to a group from Western Mass, so, and many of you may come to Dana-Farber, the Brigham, or Mass General, or the Beth Israel. Well, it's no small feat to get here. Travel time, spending pretty much the whole day. You're taking time from your family. You're taking time from work. Maybe you're accompanied by your loved ones. Well, they're taking time from work as well, which can be a problem. And then there's the expense of traveling. Not even factoring in the cost of gas now, but the traveling, the parking, and all the other issues, tolls if you're driving on the pike. So, and those are things we didn't often factor into our thought process. Was, is there a better way maybe to take care of patients where they don't have to come in to the hospital. So that's kind of where I got the idea. And my idea was to look at, really, if you see here, it's looking at business technology that is already well established. I mean, everyone knows by now you can find the closest CVS to you. I can actually find the closest CVS to my daughter in Las Vegas by punching in her zip code. So that's a fantastic, it makes life better for us. Then you have here, which is very stressful, but if you're applying for a mortgage, you're putting in a bunch of data, and it's going to spit out with you particular things that you qualify for based on what information you put in. And hold that thought, but that's something also that is very applicable to survivorship care. And then it's using communication technologies. We can use email, obviously, and we can also use our patient portal. Patient gateway is what we use. But there's also things like chatbots. There's also SMS messaging, and there's also what's called, we can use, actually, it's almost like a chatbot, but it's actually communication through the telephone, where it's a direct, voice relay of delivering messages and can interact with you on the phone. Those are amazing technologies that we've only just begun to understand how that could work also. But those are things that, this is all, keep in mind, I'll explain it later, but goes into the thought process of how can we make survivorship care more accessible, and how can we make it more affordable as well. So this is what we've developed in our clinic. We developed the virtual prostate cancer clinic. And basically what we're doing is, patients were offered in our pilot, they could choose usual care, which means traveling into Boston, getting their blood work done, getting their tests done, filling out that survey and seeing us for 10, 15 minutes, particularly if it's the doctor, and then driving back. Or we offered them a referral into what we call our virtual prostate cancer clinic. And how that works is, basically these folks that opted in, and in our pilot we were shocked, but 92% of the men opted in for this because they did not want to travel into Boston, but they wanted to remain connected to their team. So we offered them this. And then, so what you see here, give me one second. So if you see here, this is our search by zip code, and we're not working here. I am trying to figure this out. So what this is our search by zip code. I had a cool video that showed you, but basically what we did is we developed like CVS search by zip code. We placed all of the labs that report into our medical record electronically into their location, into basically API software, if you will, to create a map of, and we could punch in a patient's zip code. So for patients out in Western Mass, the closest one we have are Cooley Dickinson sites. And those sites, basically, you can have your labs done there, and it reports directly into the electronic medical record. And the reason we like to do that, and I'll tell you about it a little bit later as well, is that reports into our record. It comes directly in. It's fed into it. It gets extracted from the medical record into the software that we use directly. And that's basically been a huge bonus for us as well as the patients, because they can actually see that on their patient gateway, whereas if it was done the traditional way, it's a fax that comes in and it doesn't get recorded into the EMR as a value. It just gets placed in there as a PDF file. And this is a better way for us to do it. The administrator contacts them, sets up their first visit, and then they get a reminder, which unfortunately, again, don't seem to be able to trigger that. But basically the reminder tells them to go to the specific lab we've decided on and to get their blood work done, and to click on a link to fill out a survey about any symptoms of toxicities they might be having after treatment. And many of us have done this, every time we come to the doctor. But this is all done remotely from their home or whatever place they're at. So they go get their blood work done, the PSA is drawn, it gets put into the electronic record, it's uploaded into our software, they complete the survey, and then basically I'm going to show you an example of the APP dashboard later. And basically what happens is that stratifies the patients for us, and I'm one of the advanced practice providers in our clinic, and it helps to stratify you to basically who needs our contact the most, the quickest. And that typically that's the patients that have a relapsed PSA or have significant symptoms. And then there's a large group of us that don't have a disease relapse and also don't have significant symptoms. And those are patients that they're contacted quickly with an electronic message through our patient portal. And what that does is it explains to the survivor, like myself, that, hey, Rich, your PSA looks great. This is your PSA level. We wouldn't worry unless the PSA was over X. And then it talks about, and your next PSA is due X, and your symptom survey told us you're not having significant symptoms. So we'll send you a reminder and to go to the reminder of the specific lab to go to and get your next one as scheduled. If you have any questions or concerns, you can click on this link, which would allow them to self-schedule a visit with one of the APPs, myself, Rich, or Ashley, or they can call the office or reply to the message if they would like to talk further about it. If not, that's when their next scheduled visit is. So they're getting immediate notification that everything is okay, but if they had concerns, maybe they didn't report on there, or they just wanted to talk more because their PSA level is different than the last one, they can schedule it on their own time of when's convenient for them to talk to us. So, and that's what the electronic message was. But if they have a scheduled call already, or if they have a relapsed PSA or significant symptoms, we're going to either be giving a video call to them or calling them on the phone already, because we need that direct communication. And these are the people that we prioritize first because their needs are greater than the needs of the patients that are doing very well, meaning we need to get in touch with them quicker. But these people still get a rapid response because it's an electronic message. So basically, we'll go to the next slide. So this is just a bigger way of saying you fill out a survey, that data goes into our software that we've created. If it's a affiliated lab, you haven't done it, like say Cooley Dickinson, it gets automatically uploaded every night into our system. Or if it's outside lab that's faxed in, it gets faxed in and our administrator uploads it into the data. But then what the data we have, we'll call it artificial intelligence that knows if you've relapsed or not based on your PSA and based if you have a prostate or not. So there's different variables, kind of like the mortgage thing. And it will set you up so it tells the providers, myself or Ashley, we have a dashboard that says, okay, this patient has a relapse or significant symptoms. We need to and these are people we need to target with telephone call or video call if they're not already scheduled. And then, as I said, then there's the next group that have a normal PSA or no symptoms, and they're targeted with an initial electronic contact. So this is using technology to improve care and give patients more options. So this is just a snapshot of the last visits for 6 months. So 36% of our visits in our virtual clinic are through Patient Gateway. So 1/3 of these patients receive rapid notification, and that's sufficient for them. We also, then there's people that are scheduled for telephone calls or scheduled for video calls, and that's, about 28-30% of our patients as well. And then there's patients that aren't scheduled, but we call them. So that would be someone that's not scheduled for a visit already, but maybe has significant symptoms or they've relapsed. And then there's other non-encounter phone calls where it's medication refills, things like that. So those, so basically we've been able to replace, as you see here, out of 1,024 visits, approximately 800 of them have been replaced in-person visits for follow-up, with the medical oncologist or with ourselves. And why is that important? So, and this is just showing you that almost 60% of our lab sites are within our system, so that, again, it makes more rapid turnaround for patients, so that it's not waiting for a fax, and if the fax wasn't sent, then we have to track it down, or things like that. So that's why we emphasize that. But so this is just showing you, so by reducing, this is just information that shows we're able to reduce the follow-ups in-person follow-ups by about, a quarter. And by doing that, we have been able to increase consults each year pretty steadily, except for there were a couple of years where you see after FY19, we had a dip when COVID hit, so we didn't do as many consults because of COVID and everything else, which, but we've certainly increased it, last year with almost 1,400 consults. Because what we've done is we reduced the amount of in-person follow-ups for the medical doctors, and they've been able to see more of those new patients. So we increased consults, which you'll see here is, this is just numbers showing that by decreasing their follow-ups and using technology, and I'm calling myself highly trained advanced provider, as well as Ashley. I work with Dr. Nguyen and all the radiation oncology, but Dr. Nguyen would tell you that I know more about managing symptoms than he does. And so that's the confidence they have in Ashley and I, is because we've become experts in trying to manage symptoms of the patients we care for, which means the toxicities. And basically, this allows them to see more new patients. And so and I'll explain why it's a win-win for everyone in a sec, but this system only works really if the survivors know that they remain in the care of their specialty team, the Dana-Farber Brigham and Women's Radiation Oncology team. And they have rapid access to in-person visits anytime they either request one, if they've had a relapse or significant symptoms and want one, rather than being managed over the phone or video. But they have access. If they want the in-person visit, they can have that. It's not that we're denying them that. It's just we're offering them an easier way, and it also, they know that it does reduce the amount that the physicians can see newly diagnosed patients, which they remember what that's like. I certainly do. And also they want to make sure that the quality of their care remains the same. So through our experience, and I've showed you why providers might find this approach attractive. Well, compared to the traditional model, and everyone knows this meme, but basically the traditional model, but now patient and providers and the patients find this a very appealing way to do business, way to have their disease monitored when they know they can contact the APPs anytime they need, or that they can come in if they want to. So this is just telling you, this is our surveys. We collected over 1,500 by about 640 unique patients. And basically what they're telling you is basically they found the care, it made them more convenient, they saved time, they also saved money, and basically, it reduced out-of-pocket expenses, saved them time, and over half of them reported saving more than 3 hours each visit. So the patients like it, the providers like it, and we have patients, just to show you, we have them all over the world. We've got Alaska. We haven't updated it exactly, but in Kazakhstan, we have there in Thailand, and we have, Colombia, plus we also have a few in Brazil. But so we service all over the world, but primarily, as you can see, it's in the United States, and the majority are actually in the New England area, although Florida is gaining rapidly. So this technology, basically, so we're showing that, okay, we can monitor for disease relapse, and we can manage toxicities, But what we need to do for the next step, because we want to actually improve the patient experience for this, meaning that they can access through technology things. So the first thing we're doing right now is we're creating a comprehensive education website, so that we can build information on, so we can educate patients and empower them, because they'll know what their individual follow-up care is. So based on the standards of care, how often should a survivor be seen for disease follow-up, and what does their disease follow-up consist of? Like, do they need imaging? Do they need labs? And again, how often that is, so that they know what to expect. Because I can remember the worst thing for me was the fear of the unknown. What's going to happen next? So being able to take that away is a big thing. At least I thought so. For me and many of the patients, just helping them to know what to expect reduces one more thing that makes them feel helpless. Also, educate them about what post-treatment toxicities or side effects could occur. So educating them about what they are, educating them about what the symptoms are and why these symptoms might develop, but also educating them about how us, as we'll call ourselves the disease experts, would manage these symptoms or toxicities for them, so that they know up front, this is kind of the steps that we're going to take. So again, it takes the unknown out of it. It allows the patient to be more empowered and participate more in their care. And then also what their team would concern about relapse. So when would be worried about relapse? And not only that, but again, any patient, any survivor worth their salt wants to know, well, if I'm relapsed, what are we doing next? So mapping out, if this happens, this is what we do. But doing this in advance so patients can access this up front. But also the next step would be to build that into the technology. So remember, you're filling out a survey about what toxicities you might have. Well, wouldn't it be helpful if you filled that survey out and instantly you could get a link, or you get this information sent to you, whether it's a PDF written file, or maybe it's just a short video explaining what, okay, you have urinary issues. So you're going to get information about the specific issues you're having, as a video, or maybe as just a PDF that you can read. You can access all the information if you want on that site, but at the time you fill out a survey and you have an issue, if we can provide you with education up front, that's helpful for you, and it also helps you to understand what you should be reporting and what else. So it's a way to empower you directly. Way back in, I'm dating myself, 2014, I published information on basically survivorship care plan is wonderful, but it's this huge long document when most people really want to be able to pick and choose what information they need at the time they need it. So this is a way to do exactly that. So if you need this, we send you this, and so that would be a wonderful way. And that's what we're looking to do, is that the survey software would trigger specific information for you. And that's going to be done in prostate cancer, but we're also in discussions now with other disease centers. Is this a way that we can help patients to be able to do this in other diseases, whether it be breast cancer, where they'll need a mammogram, or they need, they need the exam and things like that, or whether it's in leukemias, lymphomas, but also in survivorship in general. Remember, what are your risks? What is your follow-up? So if this can be done, where we can send you reminders that you need to get X, Y, and Z done, and we can actually record and know that you've gotten these things done, so nothing falls through the cracks. The other thing is that it saves patients, so all of those patient gateway messages, the 36% of our visits, they're not billed at all to patients' insurances. So that means there's no co-pays for you. There's no, and actually I've had patients specifically contact me, and they've asked to stay enrolled in the program, but they do not want to schedule any visits. They want their first contact as patient gateway, because if that way it doesn't cost them anything when it's a copay or they're out of network or things like that, but they can remain connected with the team that treated them. So again, it's thinking about not only about what's good for the providers, because we've increased access to care substantially by being able to reduce the follow-up visits, but what's good for the patients too. And that's why it's important to get the survivors' feedback about what else we can do, or that they don't want to continue this type of care because it's out of network and it's going to cost them more, because they changed insurances, whereas we can offer an alternative that you can remain within our Dana-Farber Brigham and Women's system, but we're not going to bill you for that first, monitoring, information and stuff like that. We're going to let you know everything's okay, but if there's an issue, then we can call you, whether it's billed or not. But that first initial thing, whereas most people are completely fine, is done through Gateway. It's not costing them anything, because we have to be mindful not of just how it impacts the healthcare system, which just means the provider side of things, but how do we improve things for patients, and then, plus we want to build technology, as I said. So maybe instead of getting this patient gateway message, you get a text message to a link that provides you the information. So you can just click on that link from us, or you get a chatbot that's communicating with you on your cell phone. That you basically, hey Bob, your PSA looks great. We're not going to worry unless it gets over X. Your symptom survey, doesn't report any symptoms. Are you sure you're not having anything you'd like to talk about? And then we'd be able to engage you that way. So using the technology to make it more convenient for you and for us to get the information we need to make sure you're being taken care of. So this and again, this has been in discussions with using in patients with multiple myelomas to monitor things. Patients that have chronic myelogenous leukemia like I did, but I was before Gleevec and all the other tyrosine kinase inhibitors got invented, so I had the bone marrow transplant. But those patients need monitoring every 3 months to make sure they're BCR able, which is it's a lab test, a PCR lab test, to see that their level is okay. Well, this could easily be applicable to this type of approach. And all survivorship in regards to making sure they're getting their test done. Whether if it's stem cell transplant, there's a lot of risks involved with the treatment they had, and they need certain monitoring. And there's other things, the same with breast cancer patients, the same, but it's a way to empower access to care for you when you need it. And it's making sure you keep up with your visits. It's also making sure you have access to the information you need about what's going to happen in the future. And I know that there may be further questions about, and I love to talk especially to fellow survivors about their view of care. And I always want to learn from you how we can make things better, from a provider standpoint. I know I'm a survivor, but I'm also a provider, so sometimes I forget. And I need to be reminded that maybe we're not thinking about everything. And I would love your feedback. If you can see on these slides that my email address is down there, rboyajian@bwh.harvard.edu. And I welcome any and all, emails, contact. And I thank you for this, being able to talk to you about this. But this is just one small example. And certainly I can give you more details, if I'm lucky enough, maybe in the future, to give you more talks about how this approach could work on a broad scale for other diseases and things like this. But it's working very well in prostate cancer, where a large number of our patients choose virtual monitoring instead of having to come to Boston. And yes, the further you're away from Boston, the more likely you're going to want this, but honestly, I live 10 miles from Boston and it takes me over an hour to get there. So more and more this is becoming, because it's more cost effective for the patients and it increases access to care. This has been something that beyond my wildest dreams has been successful, but we always need to improve it. So I hope that you'll contact me with your ideas or suggestions about what survivors need that maybe I haven't mentioned, or you think that there's a new way to do this, or you think that there's some cool technology of that might work in the setting of survivorship care, and in being able to take care of these patients slash survivors that have been done with treatment but need care as well. And that also includes patients that maybe they're not done with treatment, but they still need monitoring for things. We also take care of patients that are still on active treatment but need monitoring remotely as well. So this is not just applicable to patients that are done with treatment. This is another way to manage patients that are on treatment that maybe, they need more monitoring than just when they come in, or to spare them from coming in all the time. So this isn't just for patients after treatment, but that's primarily what we focus on right now. And again, I thank you, as a provider to be able to deliver this talk, but as a survivor even more to know, just to let you know that there are people thinking about new ways to do things to hopefully provide options for you in your survivorship care. And again, thank you very much, and I look forward to talking to you again.